My name is Dinesh Khanna. I'm a rheumatologist at University of Michigan, and I direct the Scleroderma program there. So today we'll talk something that is very common in people with Scleroderma, which is the gut involvement. Before we do, there are two Scleroderma Foundation medical reports that I have been part of. The first one on the left has been updated, called the gut or GI involvement in Scleroderma. I just updated in 2019. The other one is Eating Well with Scleroderma, that was written with Linda Kaminsky, who's a patient of mine, but also a nutritionist, and myself. When we think about the gut involvement, we think about the esophagus or the food pipe, the stomach, the small bowel, the large bowel, rectum, and the liver. So these are the areas that I will talk today. Here's the anatomy of the gut or the digestive system. You have the mouth, and then you have the esophagus or the food pipe coming down, followed by stomach on the left side of the body. The liver is on the right side of the body, the small bowel, the large bowel, and the rectum. Why are we talking about gut involvement? Because 70 to 90% of people with Scleroderma have some kind of gut involvement. Most of the people have symptoms, unlike lung fibrosis or pulmonary hypertension, where you may not be symptomatic. Most of the people have reflux or heartburn, dry mouth, diarrhea, constipation, and other aspects. And it does interfere with your day-to-day activities and has a big impact on your quality of life. About 10 years ago, I did a survey at the Scleroderma Foundation meeting. And this is what the survey of 209 people with Scleroderma taught me. This is the prevalence of GI symptoms. 71% had heartburn, 52% had trouble swallowing, 80% had bloating, 51% had diarrhea, 51% had constipation. But what really surprised me is that 1 in 3 complained of fecal incontinence or rectal incontinence. That, to me, as a rheumatologist, was a big surprise. So let's start. What is the function of the gut? And in lay person term, it's to push the food down, extract and absorb the nutrients. It does it by a well-orchestrated motion of the gut muscle, which in medical term is called peristalsis. The gut involvement in Scleroderma, the primary event that causes trouble in the gut is the weakening of the muscle motion in the gut. Virtually every gut symptom that you have is because of increased collagen deposition, slow death of the nerve cells that control the motility of the gut, and the weakening of the gut muscles. The weakening usually starts in the food pipe and slowly and progressively works its way down to the small and large bowel. So we'll start with the oropharyngeal or mouth involvement. Many of you, I'm sure, have dry mouth, dry eye syndrome, which we call as Sjogren's syndrome. And approximately 20 to 30% of people with Scleroderma have a dry eye, dry mouth syndrome. It can interfere with eating. It can interfere with swallowing water and other aspects. And I'm showing you two patients of mine. This one has decreased oral aperture or the mouth opening, and you can see the crowding of the teeth. That's because of Scleroderma. The person had perfect teeth before the Scleroderma started. And the lower one is showing really dry tongue with a little bit of inflammation at the angle of the lips because of this. I don't have a lot of input what you can do because these medications such as pilocarpine and cevimeline do not work very well. The key part is to take small size of the food, liberal fluid intake. I think the most important thing is regular dental appointment. These are the oral moistures and protection that you can use. I've listed some of them here, and they really come from Dr. David Leder, who you may have heard yesterday. He's a dentist at Tufts Medical College. So I've learned these therapies that are available, they're sugar-free. so that you can use, and most of them are available at Amazon.com. Adaptive devices, very, very, very important. You want to clean the premolar and the back of the teeth. The patients with scleroderma get much more decay of teeth compared to if you did not have scleroderma because of the dry mouth, dry eye syndrome. So here are different adaptive devices that I'm showing you. So let's go down. Let's go to the food pipe, talk about the reflux disease. It's a liquid content of the stomach that comes up or regurgitates or back up or reflexes into the esophagus, also known as gastroesophageal reflux disease or heartburn or GERD. Again, it's caused by the weakening of the gut muscle, but also weakening of the sphincter that is between your food pipe, esophagus, and between your stomach. All of us have that sphincter. When you eat something, the sphincter opens up. The food goes down, and the sphincter closes back. In scleroderma, it's flapping. So what happens if you eat a pizza? And you go home, and you lie back, the sphincter opens up, and the food comes up. So you need to understand why you get a lot of heartburn, a lot of regurgitation. A patient just told me that they get the regurgitation of food, which is the food coming up in your mouth, or you taste acid in your mouth. And the symptoms of reflux are not just heartburn. Heartburn is one of the most common symptoms, but people may complain of difficulty swallowing, chest pain, mouth ulcers, change in the voice. You wake up in the morning and your voice sounds different. It's more hoarse. Chronic cough, especially at night or when you wake up in the morning, and new onset asthma. In other words, you are aspirating the acid and the non-acid aspects of the stomach into your lungs. And if not treated over time, you can develop these ulcers, or called stomach ulcer or food pipe ulcers that you see here, that may lead over time to the strictures. So what happens is that you start noticing you had a chicken bite here, and the food gets here, and it gets stuck in your food pipe. And you have to drink a lot of water. Over time, the smaller the size of the food, the more difficult it gets till you start to choke, even drinking milk or other fluids. So the management or treatment is to manage and treat this part so you do not develop a stricture of your food pipe. Why do we need to treat? Well, first of all, to relieve symptoms. You can't walk around. All of us have had heartburn, right? We can't just walk around with heartburn all the time. We need to relieve the symptoms. I talked about that the acid that is produced in the stomach may flow back while sleeping and get into the lung, causes lung inflammation. You heard Dr. Steen here talk about lung fibrosis. Some of us think that acid reflux may cause lung fibrosis, or it can worsen lung fibrosis. The other aspect is that it can cause cancer of the, very rarely, I want to emphasize that, it can cause a precancer and a cancerous lesion, and I will talk about this. So this is probably the most important slide of the whole talk. So if you just came here for 10 minutes, you can listen to this, and then you are done. The anti-reflux measure, sleeping with the head of the bed elevated. Either you can use a wedge pillow, there are many of them at Amazon.com, or you can raise the head side of the bed. If there's one thing that you take from the conference regarding the heartburn and lung fibrosis, is sleeping at an angle. I hope none of you smoke, but if you do smoke, it's important not to smoke. Take small meals, the biggest meals at noon, and as the day goes on, you start to take smaller meals, because otherwise the food will just stay in the stomach. I will talk about gastroparesis or poor gastric emptying. Frequent meals, and try not to use very tight garments in the stomach because it does propel the food up. So again, only raise the head side of the bed. I have had patients who have raised the whole bed. So you have to be aware of just the head side of the bed. So there are two ways to do that, but If you do aspirate, if you do taste food in your mouth, sleeping at an angle, this is difficult. Wedge pillows are difficult to get used to. Most of my patients are able to raise it by 4 to 6 inches. We will talk about the therapy. We talked about the smoking. I never tell anybody to avoid chocolate. That is not appropriate, but you need to know chocolate and coffee can lead to incompetence of the valve I talked about and can cause more reflux, and so can medications such as nifedipine that you use for Raynaud's phenomenon. There are multiple medications that are available. Which is the best medication? The best medications of all this is the cheapest one, and that is covered by insurance. So most of the patients start over-the-counter Prilosec at 10 milligram once a day. But majority, if not all, require 2 to 4 times that is used in general population. There are a few reasons. Number one, the valve is incompetent. Number two, the stomach motility may not be good. So if you had a pizza or you had a big breakfast today, the food just sits in your stomach. And as you lay back, the food starts to push up, the valve is not working, so you start to have heartburn and other symptoms. Most of the patients do well. If you do not do well on Prilosec, we try the next one, Prevacid. If you don't do well on Prevacid, we go to Acifex. So we try different therapies till you have a therapy that works for you. But all these therapies are useless unless and until you do this. So you have the control to control, you have the control how to capture or take care of your reflux. There are a lot of concerns on proton pump inhibitors, so I wanted to address it for the audience. Diarrhea, there have been a lot of large databases that have showed people might get an odd kind of diarrhea called C. difficile infection, where people have bloating, abdominal pain, bloody diarrhea. There's a risk of osteoporosis. There have been publications on dementia and chronic kidney disease. We need to make some sense what has been published. Most of it has been from the large insurance claims database and large single insurances. There's really no information about scleroderma. These are millions of people that might be in the VA database, Veterans Affairs, Medicare, Medicaid, Kaiser Health System. I think although the effect may support role in large population, it is unknown what effect it may have on you. But if you take a proton pump inhibitor, if you really take your medication regularly and you say, and which is about 15 to 20% of my patients, they say, I continue to have heartburn on a daily basis. So these are some of the few things that I do. I again reiterate sleeping at an angle. I add Pepcid or Zantac at 9 type to the reflux. If I feel that your stomach motility is not working well, which we will talk in the next section, we add something called a prokinetic medication to increase the motility of the stomach. So the food can be pushed from the stomach into the small bowel. There is a non-prescription medication called Gaviscon, which floats on the top of the stomach content and prevents from having reflux. I've learned this from our gastroenterologist. Another one is sucralfate, which protects the stomach lining, baclofen, which increases the pressure of the sphincter we talked about, and sometimes people have fibromyalgia of the gut, what we call visceral hypersensitivity, and using antidepressants may actually help with IBS-like irritable bowel syndrome-like symptoms here. So these are the few things that this is available on Amazon. So you can buy that. The other medications I talked about are prescription medication. Here are some of the pro-motility medications: Reglan, erythromycin, domperidone, Propulsid. All these medications are associated with what we call QT prolongation. So it may have an impact on your EKG, electrocardiogram. So you must get an electrocardiogram before you go on these medications. Some of these medications are not available in US. So if you do tend to take it, be aware of the side effects. In my all these years I have practiced, I do not think that they have a huge success. They do work a little bit, but they are not blockbusters like proton pump inhibitors, which really help you with the heartburn and reflux. I wanted to touch briefly on Barrett's esophagus, which is the precancerous lesion in long-standing patients of GERD. It is in about 10 to 13% of people who are taking proton pump inhibitor. Here I show you a picture that I took from the WebMD. And you see the normal mucosa, and then you see this mucosa out here, which is a little bit more reddish, salmon-appearing color. And if you do a biopsy of it, it would be a precancerous lesion. Why do we worry? Because rarely it can go and develop into a cancer of the junction of the food pipe and the stomach. So a lot of patients come and say, we don't want to take proton pump inhibitor because it will cause osteoporosis. It will cause dementia. But chronic reflux, chronic acid damage to the food pipe, the junction of the food pipe and the stomach can lead to, and once you have this, you need to go to a gastroenterologist on regular basis. Some of the people get yearly endoscopy with biopsies, random biopsies, to make sure things are not progressing. So we'll move to the stomach now, and we'll talk a little bit about the motility of the stomach. The main problem encountered is slowing emptying of the stomach into the small bowel. If you have food sitting in your stomach, you might feel bloated. Bloating meaning you feel that your stomach is about to explode, or you see that the girth of the stomach is going up, nausea and vomiting, abdominal pain, excessive flatulence, and results in weight loss. There are three main reasons of weight loss in a person with scleroderma: depression, which is probably the leading cause, poor motility, and having bacterial overgrowth. I will talk. And then the fourth one I can add is if you can't chew your food, if you have difficulty, or if you don't have good dentition or difficulty swallowing, that's also a cause of weight loss. Diagnosis is usually clinical. So if a person comes to me and say, I just get bloated and I can't eat much. I have 1/4 of a hamburger and I'm full. And the food just sticks around and I feel bloated and I keep on burping and I have nausea and vomiting. Those are the symptoms that are suggestive of poor gastric emptying. We can also do a gastric emptying study where we give a radio-labeled material and see how long does it take for the food to go down. So here's a patient of mine who has scleroderma but has normal gastric emptying study. Time 0, they get peanut butter and jelly sandwich that is radio-labeled, and in about 60 minutes, 75 and 90 minutes, you see the food is out of the stomach and into the small bowel. We have people, 90 minutes, 90% of the food should be out of the stomach into the small bowel. There are patients of mine where it stays there for 24 hours. So this helps if you are not getting better by taking small food. So you can eat 5 to 6 times a day. You can take pro-motility medications that would be helpful. And I think the treatment of GERD would also help with this aspect. Very rarely, you might develop something called watermelon stomach. Has anybody here ever had watermelon stomach? So about 5 or 6 of you. Watermelon stomach is called watermelon stomach because it looks like watermelon. So here's a patient of mine who, this is the part of the stomach, and it looks like the outside of the watermelon. And you see these small telangiectasias, which you have on the face and your hands and your mouth, they can occur in the stomach, and they can ooze blood. So people usually come with feeling tired, fatigued. We do their hemoglobin, and the hemoglobin is quite low. They have anemia. And the gastroenterologist goes in there, does an endoscopy, and sees this classical finding. So here's another patient of mine, has watermelon stomach on the left slide, and the gastroenterologist go in there and do organ plasma coagulation. So they really have to burn off these areas, trying to help and get rid of these oozing spots. Fortunately, it is very rare. It's about 5% of people who have, 5 to 10% who have early scleroderma. I'm going to go down to the small bowel and then to the large bowel. The small bowel is the part of the gut that absorbs nutrients from food. And again, lack of muscle tone, poor motility leads to stagnation of food, bacterial overgrowth, diarrhea, cramping, bloating that we talked about. So this is probably the most common cause of GI-related weight loss, where the bacteria, all of us have healthy bacteria in our large bowel. But when the gut is not moving, the tone is lost, the food is not, the tone is lost, the gut is moving slow, this bacteria can come into the small bowel and start, quote unquote, competing with the nutrients and the food you're taking. And it is called small bowel bacterial overgrowth. It causes weight loss and inability to gain weight. It can cause malabsorption of essential vitamins and minerals. Again, it's more of a clinical diagnosis, but if we are not sure whether the bloating, distension, weight loss is coming from gastric emptying problem or bacterial overgrowth, we can do a hydrogen breath test to make a final diagnosis. You can increase the motility of the gut, but the key treatment is giving you chronic cyclic antibiotics to decrease the load of bacteria in the gut. Here are some broad spectrum antibiotics. Most of us trust with Augmentin, Cipro, Flagyl, but there is a medication that may be a little bit hard to get approved from insurance called rifaximin. So this medication is not absorbed in the overall body, and it does work really well, or called Xifaxan is a trade name of the medication. We talked about some of the pro-motility agents before. We generally use antibiotics, can be used every 2 weeks on, 2 to 4 weeks off. Some people need an upfront loading dose of antibiotics so you can really reduce the amount of bacteria. Same or different antibiotics are used depending upon physician preference and your symptoms. Make sure you get a bone density scan if you do have bacterial overgrowth, because it's probably causing mild to moderate osteoporosis. And if you have scleroderma, in general, I tell my patients to take a multivitamin, calcium, 500 milligrams 3 times a day, and 800 international units of vitamin D. Probiotics. How many of you take probiotics here? Everybody takes probiotics. And why do you take probiotics? Because it is healthy to take probiotics, right? And everybody feels it does work. So probiotics are quote-unquote bacteria that have a beneficial effect in the prevention and treatment of gut problems when they are ingested. If you look at irritable bowel syndrome, IBS is irritable bowel syndrome, there have been 43 trials that have been done that have shown some impact on the abdominal plane, bloating, and flatulence. So it does seem to have some impact in IBS. I think effect of individual species. You take Align, you take Cultural, you take Costco brand, you take Sam's brand. I don't think it matters which brand you are taking. It seems to have no impact on that. Just be careful, probiotics are live bacteria. There have been very, very rare cases when you're getting chemotherapy for your lung fibrosis. You are just had a bone marrow transplant. That these live bacteria can actually cause blood infection, what we call sepsis. So if you are really immunocompromised, you're taking mycophenolate with high doses of prednisone, mycophenolate, or Cellcept with methotrexate, you have to be careful that these are live bacteria, and your immune system should be able to ward off or fight these bacteria, because these bacteria are not part of you. These are the bacteria that you're ingesting from outside. I just have one slide on nutrition that talks about, people always ask, what should I take, what I should not take? And there's something called FODMAP diet, which is the fermentable oligosaccharides such as fructose, lactose, sugar, alcohol such as sorbitol, that can help with the bloating and distension. if you try to do the FODMAP diet, you must see a nutritionist. Do not start it yourself, because if you take the essential food out of your diet, you need to replace it with some other nutritious food. You're already losing weight. If I tell you to stop eating wheat, dairy products, but do not tell you how to replace with another food source, then you're probably going to lose more weight, and that's not the intention out here. The intention is to help you with symptoms of distension, bloating. I have 1 or 2 slides on pseudo-obstruction, where pseudo-obstruction is when the bowel says that I'm not really blocked, but I had just enough and I do not want to work anymore. And that is an extreme case of bacterial overgrowth. There's such a high load of bacteria and such poor motility of the gut that the bacteria are stagnated there, and it really causes belly pain, distension, vomiting, and the key part is people are not able to pass gas. They really come bloated 3 to 4 times to the ER or urgent care. They're throwing up, and it's diagnosed by X-ray and CT scan. And here's an old picture showing how much the gut is dilated out here due to pseudo-obstruction. It is not real obstruction. So you are your own advocates. You go to the ER, your stomach is distended, they do a CT scan, and a surgeon comes in. And they say, you have an obstruction, I'm going to take you to OR. Now, people with scleroderma can get real obstruction. But you need to let them know that I have scleroderma, I have been told it may be pseudo-obstruction, and could you make sure that all I need is rest of my small bowel, IV fluids, pro-motility agents, antibiotics, and could you call my rheumatologist, and if you do not have a rheumatologist in that area, could you consult a rheumatologist before we do surgery? None of the obstruction cases need to be done immediately. They have to be done within 10, 12 hours, but there is some time that you can wait. It's very rare. How many of you here had pseudo-obstruction ever? So I see 3 hands out here, so you can see in an audience of about 80 to 90 people, it is quite rare to have pseudo-obstruction. The large bowel, the function of the large bowel is to reabsorb water and salts that have been secreted and help the formation of the stool. So what is constipation? There's a medical definition of constipation, and the biggest part of that definition is that you get hard or lumpy stools, you have incomplete evacuation and straining during the bowel movement. It's caused by weakening of the gut muscle, and I'll talk about the stimulant laxatives that act on the nerve endings in the gut that makes the muscle in the large bowel contract and push out. Fluids do help, but if you just take high fiber diet without any stimulant laxatives, and if your constipation is due to slow-moving bowel, then you will just make it worse. Think about adding a lot of fiber and not having any force to push the fiber out. The fiber will just get stuck there, and it can really form hard, lumpy mass. People who have constipation, they take Miralax or therapy when they're really constipated for 3 days, and then they stop it, and they get backed up again. A week later, then they take Miralax for 3 days. That's not the goal or the hope of treating constipation. You have to have good bowel regimen where we take it every 2 to 3 days. Here are a few stimulant laxatives that I have put here, but if you feel you're obstructed, you're throwing up, that's not the time to take, because your gut has told you, I don't want to work. So that's not the time to force the gut when the gut really does not want to move. I want to show you 4 medications that have been approved, and some of you might be taking these therapies that help either to promote fluid secretion in the bowel or work in the bowel to increase the bowel motility and peristalsis. All these 4 medications are either approved for chronic idiopathic constipation or irritable bowel syndrome associated constipation. So if you continue to have constipation despite taking over-the-counter Miralax, the stimulant laxatives that I showed here, it is important to talk to your rheumatologist or gastroenterologist. Most of them, like the pro-motility agents, require a baseline electrocardiogram to make sure you do not have any abnormal QT prolongation. And then there are antidepressants in irritable bowel syndrome. A lot of work has been done with bloating distension. This is a large study, what we call meta-analysis of 16 randomized controlled trials showing that people who have fibromyalgia of the gut or visceral hypersensitivity, tricyclic antidepressants actually do a good job. So if you continue to have this distension, bloating symptoms, your rheumatologist or gastroenterologist have ruled out bacterial overgrowth, pseudo-obstruction, you have taken probiotics, but it's just having a big impact on your quality of life. You're constipated one day, diarrhea the other day, distension, bloating, it may be worthwhile a trial of low-dose tricyclic antidepressants. We'll move to the rectum, where stool incontinence, as I pointed out before, occurs in up to a third of the patients. It's due to weakening of the rectal muscle and poor control over the rectal sphincter. The treatment is biofeedback therapy, where strengthening of the rectal muscle by volunteer squeezing of the muscles and taking anti-diarrheal agents. If you're fortunate, you can get interstim placement. Interstim is a device that is put and stimulates the sacral nerves. Sacral nerves are the ones that control both your bowel and bladder contraction. So what a surgeon does, a colorectal surgeons, they put in a temporary interstim in the back near the tailbone, and they see whether that would be helpful. It's a pacemaker. It's a pacemaker to improve the motility and the contraction. And let me tell you, if you're fortunate enough that you have a surgeon who would do that, and this is really having an impact on your quality of life, you should definitely consider that. This is a small chip as thin as your credit card, and it's placed just above just below your tailbone, I should say. Liver plays an important role in the detoxification of the drugs in the body. Approximately 10% of people with scleroderma have liver involvement called primary biliary cirrhosis. It's an autoimmune cirrhosis. It's not alcohol-related cirrhosis. It's an autoimmune cirrhosis. Usually, it occurs 10 to 15 years after scleroderma onset, and usually it's associated with limited cutaneous scleroderma or CREST syndrome. So people who have anti-centromere antibody. The symptoms are you are doing fine and you start to itch a lot. You're itching a lot, you're getting fatigued. And when we do a blood work, a regular comprehensive panel, we find that your liver function test and your bilirubin are elevated. There are specific tests that we can do, anti-mitochondrial antibody and anti-smooth muscle antibodies that can help us make a diagnosis, and there is good treatment available if you start it early. You have to see a hepatologist. They usually do a liver biopsy to look at the fibrosis and inflammation. But if you are very late in the diagnosis and the liver has failed with fluid in the belly called ascites or other signs or symptoms, then you may need a liver transplant. But it is rare. Anybody here has primary biliary cirrhosis? One. So it is rare, but it's good. Again, scleroderma is rare. This is even more rare. So you have to be your own advocate. The goal of the lecture is to give you what may happen. It's not saying that this will happen, what may happen, and you know and you're aware of it if you start to develop these symptoms. I want to end the talk with something that I developed at UCLA, which is called the UCLA Scleroderma GI tract instrument. And this was done with Dr. Daniel First, who is my mentor, trying to capture the GI involvement in people with scleroderma. It's a 34-item instrument that is being used for clinical care and clinical trials, and it takes about 8 minutes to complete. It has these various domains. How much reflux are you having over the past 7 days? How much distension, bloating, diarrhea, constipation, fecal soilage? And more importantly, what impact does it have on your day-to-day functioning? So every patient, so you can put UCLA SCTC, and here is a link, and you go here, and you can say that I want to do screening for myself or somebody else, or you can click on this interactive tool. So all our patients who come to Michigan complete it on a tablet. So we give a tablet where we look at the physical function, we look at the pain, and we look at the GI symptoms. And when the patients come into the room, I see this. So here's a patient of mine who has these symptoms going on. A lot of reflux. Red is a concern. Your GI symptoms appear to be causing some of the issues. Talk to your doctor. Yellow is of some concern, and you may consider talking to the doctor, and green is good. So here's the patient has quite a bit of reflux, but really distension, bloating. The patient is having fecal solids, diarrhea, constipation. It's all over the place. In a 20 to 30-minute visit, when I'm seeing a patient and talking about their overall well-being, doing a skin score, looking at the pulmonary function test, looking at the echocardiogram results, looking at the CAT scan if it was done, talking about other aspects, having the snapshot in front of me really tells me today I need to spend some time talking about the GI involvement. Whether teach about the non-pharmacological management such as sleeping at an angle, sending to a gastroenterologist to do an endoscopy, but it really tells me, it's a very telltale sign to me that I need to do something about it. So it's a snapshot that makes me initiate a discussion with the patient who is sitting in front of me. You can go, it is free. If you want to do it, you can just type it, and it's available through the Michigan website. So scleroderma, as I showed you, affects about 90% of the people, has a big impact on quality of life. There are good tests that are available to find the location and extent of involvement, and appropriate treatment, especially of some of them, are quite effective.